everyone. Good afternoon or good evening. I hope you're all doing very well, and thank you for joining me on time. Very good. So as you know, this is the final class on oculoplastics. This is the 14th class under the series of mock clinical practice. So I named this class Miscellaneous because we are going to shed the light on different topics, a lot of questions, all right? And that's why I advise you all to take notes, as I always say, because sometimes you may, while you are watching or listening, you may feel that you will remember this piece of information, but believe me, you may forget it. Especially whenever I say something new or like something you are not familiar with. So you have to jot this down and write it down in your study note or your notebook that you need to revise this after the meeting, for example. So as he says, the faintest ink is more powerful than the strongest memory. Okay, I want to emphasize again, I'm not going to spoon feed you information with a lot of information. It's not my responsibility to tell you every single detail. I'm just trying to highlight some important questions, and you have to do a lot of work on your own. So you had to put in a lot of effort in order to know everything about the important topics. And as you know, this is an interactive session, as always. So I'm waiting for your interaction and participation. Okay. So although it's a miscellaneous class, but we have the same time frame. We have some opening slides, followed by clinical tests. If you remember, I usually say checklist because previously we were talking about specific topics like proptosis, ptosis, but here we have some miscellaneous clinical tests. Next, some cases based on past candidate experiences, followed by the fun part, which is the questions part. And the last is some closing slides. So let's start with the opening slides. So the opening slides is all about something I called breaking news. All right. So what is the breaking news here? You have to know that anticipation is one of the keys to success. So you have to have some prediction about what you are going to face in the exam. Okay. This is really important. Let me elaborate on this. So we usually say that we have 4 stations in the final FRCS exam, okay? So we expect slit lamp biomicroscope, the anterior segment station. We expect indirect ophthalmoscope plus 90 in the posterior segment. But in the other 2 stations, we don't expect any devices, okay? It's just you and patient and the examiners. But according to some recent experiences, now you may experience or you may find slit lamp biomicroscope and even plus 90 or any device to do fundoscopy in the other 2 stations, the neuro station and the oculoplastics station. And let me give you an example. So in neuro station, for example, there was an experience where the candidate talked about a case with, he elicited as a sign, the case has RPD, relative afferent pupillary defect. Then the examiner asked the candidate to examine the patient on, slit lamp. I don't remember, but the examiner asked the candidate to do fundoscopy. And the candidate found some optic disc abnormalities. So don't be ever surprised if the examiner asks you to do something like fundoscopy in neurostation. Another example that happened in oculoplastic station, the candidate was asked to examine the case in oculoplastic station on the slit lamp. And what was the sign? The patient has silicone tube, okay, bicanalicular silicone tube. Or maybe another imaginary situation, the patient may have like some eyelid margin abnormalities or some swelling that may be more visible on slit lamp than using your naked eye. So there might be eyelid margin abnormalities or masses on the eyelid margin or other secondary effects on the cornea or conjunctiva in oculoplastic station, okay? So as you see, all stations are really connected together, all right? So this is actually the opening slides, too short, too sweet. The next part is the clinical tests. So we are going to discuss some miscellaneous clinical tests. The first one is regurgitation test. And then we have the fluorescein disappearance test. examination of the main lacrimal gland, upper eyelid eversion, and finally, vital states. I shared before the video, and now we are going to discuss the video clip by clip. Okay. Let's start with the regurgitation test. So those who watched the video, okay, so I need someone to volunteer to narrate the video. So as you know, the video is like silent, okay. I need someone to volunteer to tell me about the test or just explain what I am doing in the video. All right? Okay. Have you watched the video before? My video?
Yes, madam, I watched the video.
Okay, so let's start. So my first question, say this test, name it, like pronounce it.
It's a regurgitation test.
So by the way, it's not written in Kanski under this name, okay?
Yes, it's not written in
It's not written.
yes.
It's only description.
Yes, you're right.
Yeah, in Kanski, it's kind of description of the test without giving a name, okay?
Yes.
Excellent. So I'm going to ask you some questions, okay? Because this is an interactive. Why am I wearing gloves? Because usually I don't wear gloves while examining the patient. Is it necessary to wear gloves before doing such tests?
Because, madam, regurgitated material may come to your face or your eye. It may cause infection, contamination.
Okay, so yeah, to protect, because you are going
to protect yourself, yes.
Yeah, to protect yourself because there might be regurgitation of pus. This is infective substance, so you have to protect yourself. Otherwise, you don't need to wear gloves while examining the patients, generally speaking.
Yes, madam.
Okay. So I wrote here, yeah, you have to inspect like few seconds.
You are inspecting the patient for any swelling, redness, or maybe fistula of nasolacrimal duct may occur in some patients. So we should inspect for this signs.
So you mentioned, okay, you mentioned redness and you mentioned
redness, swelling.
Swelling, okay, so don't forget swelling. It's very important because if we have a case of acute dacryocystitis with a swelling, it's actually a relative contraindication to do this test.
Yes.
Okay, and you mentioned also fistula.
Fistula,
okay.
yes.
Yes, exactly. But you can add more like scar of the previous DCR. Yeah, many things.
Yes.
So, yeah.
Now you are checking the position of the punctum.
Yeah, so because lacrimal drainage system starts with puncta, so you have to make sure that the puncta are okay, are present in the first place.
Or there is any stenosis.
Yes, stenosis or atresia or anything. Okay.
Atresia and anything, yes.
And of course, you can do all of this on the slit lamp as well.
Slit lamp again, yes.
But here I am using my naked eye plus pen torch.
Yes.
Okay. Of course, it's much easier to see the lower punctum. Here I'm checking what?
Upper punctum.
Upper punctum. It's much easier to check the lower punctum, but the upper punctum you need to do some manipulation, retract the upper eyelid and see it.
Yes, ma'am.
Here.
And now you are checking the displacement of the punctum laterally.
No. I'm not testing the laxity. You are talking now about the laxity. But I am doing something called lateral traction, okay?
Lateral traction, okay.
Of the eyelids in order to put the medial palpebral ligament under stretch, okay? And I can palpate it. I can feel the cord-like structure of the medial palpebral ligament, okay? What's important of this? Because you have to place your finger below the ligament.
Medial counter ligament, yes.
Okay. After you place your finger, there is no need to apply traction anymore.
Okay. Okay, thank you.
And here?
Now, madam, you are just pressing the lacrimal duct.
Sac.
Yes, lacrimal sac.
While observing, it's very important to see.
And observing for any regurgitation of the any material.
Yes, of course. But don't forget while, because sometimes you press and you are talking with someone else. While you are pressing, you have to observe for any regurgitation. Sometimes it's very subtle. Okay.
Okay.
Here I'm just repeating the test once more. Okay. But of course,
you say it's a traction test.
No, it's not a traction. It's just a step.
It's just a step.
A step.
For facilitating to palpate the medial palpebral ligament?
Yes, in order to put your finger on the exact position. Position below the ligament, okay? But of course, if you have a positive regurgitation test, if you repeat it after a few seconds, it would be negative, okay? But here, for the sake of teaching, I'm repeating the test. We don't expect they allow you to do this in the exam because it takes some time for the sac to accumulate fluid once more. So if we have a positive test and we have regurgitation, if you repeat the test, the next time it would be negative, like false negative. All right?
Yes, you're right.
Did you get it? Okay.
Yes.
So I'm here just repeating the test. I want to identify the position of the medial palpebral ligament, okay? And you can see it also. You can see this cord-like structure, okay? Connecting the inner cancers to the lateral orbital bone. And you place your finger below it, okay? And you may ask the patient to look up to easily see the lower punctum and look for any regurgitation on pressure, okay? And of course, you need to do it bilaterally. Even if the complaint is unilateral, even if the complaint is unilateral, you have to do it bilaterally.
May I ask something, madam? Is this step necessary, or just we can put our fingers just under the medial condylar ligament and press it?
So
we should do this step.
I don't know, but it's very easy. I think it's not necessary, but this is how my mentors, my professor taught me before.
Okay, madam. Thank you very much.
It's okay to use a cotton bud or like Q-tip applicator instead of your finger.
Yes, you're right.
So I'm here repeating the test using cotton bud instead of my finger. And you can use any finger. So because some say you have to use the little finger, it doesn't really matter, okay? And you can do it the same on the slit lamp, as I said before.
In my practice, madam, I do most of the time under the slit lamp.
Okay, because this is a must do test before cataract surgery, before any intraocular surgery.
Yes.
You have to make sure that there is a negative regurgitation test. Okay, so away from this test, you can also, as a part of evaluation of the lacrimal sac, to palpate the lacrimal sac. You may feel mass or stone, although it's very rare, but this may be added. But this is not related to regurgitation test. Thank you, doctor. Thank you so much. I need someone just to read aloud this slide. So for shy people, just read it aloud. Yeah.
Good evening, ma'am. I'll read.
Okay. And this is taken from the well-known website, it's India-based website. Yeah, please read it.
Regurgitation test. A steady pressure with the thumb is applied over the lacrimal sac below the medial palpebral ligament. Regurgitation of fluid on pressure over the lacrimal sac, it's also known as rhoplas, is indicative of an obstruction in the lower lacrimal drainage system. The fluid may be clear, mucoid, or frankly purulent, depending on the quantum of infection present in the lacrimal sac.
So as you can say, Doctor, in my area, we are not accustomed to say this abbreviation, but this is another name for the test.
Yeah, it is
So,
commonly used in our country.
yeah, so we never use this in Egypt, I believe, at least in my area. But this is actually, this is like an abbreviated or like acronym. So RUPLAS. So this is how you pronounce it. So RUPLAS. Okay. And you
Regurgitation
have to,
on pressure on lacrimal apparatus system.
so it's not all the system, it's only the sac. Okay.
Sac, yeah.
Okay.
Yeah.
And you have to comment on the nature of the fluid. Is it clear or mucoid or frankly purulent? And sometimes you may be interested to say if it is coming from the lower punctum alone or upper or lower, other things. Okay.
Right.
All right. So when I say there is a positive test, what does it mean, Doctor?
It means that there is regurgitation and we are able to see some fluid, mucoid or purulent or watery coming from the lower punctum or both punctum.
And this means?
This means that there is distension and collection of fluid and infective secretions in the sac because they are not being drained through the
Okay.
nasolacrimal duct. Obstruction in the distal part of the.
This means
So
there
it
is an
means that
obstruction?
there is a collection of fluid in the lacrimal sac because there is obstruction to the outflow in the nasolacrimal duct or in the distal part of the lacrimal system.
Okay, so excellent. So if we have a positive test, this means we have most commonly the obstruction at the level of what?
Nasolacrimal duct. Most commonly, it's in the acquired in the adults, it is at the middle level, and in congenital obstruction, it is at the most distal part, that is the valve of Hassner.
Excellent. So of course you have to classify, is it acquired or congenital? It depends on the onset or the patient's age. Okay, but if I ask you, positive test means nasolacrimal duct obstruction plus another thing. Can you guess? In order to have a positive regurgitation test, there must be nasolacrimal duct obstruction and collection of fluid in the sac, as you said, but there must be another thing.
There must be a patency of the proximal
Excellent.
lacrimal.
Excellent. So there must be patent upper system. And that's why, if you remember in the video, I said we need to check or document the patency and the presence of the punctum.
Punctum, yes.
Okay, thank you. So it really doesn't matter which finger, because here is one of my professors always says little finger. It doesn't really matter. Okay. And here is from this book using the Q-tip applicator. And as you can see, this is like positive regurgitation test, or as you say, RUPLAS, and this is a purulent material. Of course, it's not enough to know this, because you have to know what's the next step in the evaluation, what's the implication, what does the patient need afterwards. And again, the protocol for nasolacrimal duct obstruction treatment differs according to is it congenital or acquired. You have to know this protocol very well. Here we have the medial palpebral ligament. It has two parts, one anterior to the sac and one posterior to the sac. So this is like a posterior part or cross, and then another one in front of the sac. We usually place our fingers below the medial palpebral ligament. So I need someone to tell me, is there something wrong about this slide or on this slide? I said we have to press here. So this is like a test of your observing power. How about the orientation of the hand here? Is it okay?
We have to do it from the medial side.
Yes. So the direction of pressure. So this is actually a wrong orientation of the hand. So the direction should be like this. Upward, medially, toward here, okay? Upward, medially, and backward. This is the direction of our fingers. Yeah, maybe not important, but yeah, in order to make it like perfect. Okay, doctor?
Yes,
Okay.
madam.
If you go back to the video, you will find that the way I press is like this, upward, backward, and medially. So you have to know a little bit about the anatomy. Can you tell me what we call this area? Do you see the laser pointer?
Yes, yes.
What is the name of this area?
So,
This is inside
you
the
mean
nose.
the
Mhm.
inferior meatus,
Okay, so the opening of the nasolacrimal duct in the inferior meatus. Okay, and what we call this one?
middle meatus.
So what's the importance of middle meatus?
So when we are doing the dacryocystorhinostomy, the opening is into the middle meatus.
Excellent, excellent. And as you know, the meatus is below the turbinate. So if we have the inferior turbinate here, the meatus is below it. One last thing here, in my area, sometimes we say regurg test as a kind of abbreviation, but actually this is not a standard English. The full name or the accurate way of saying this test is regurgitation test. Or maybe if you are going to sit the exam in India, you may say this. Yeah, very interesting. Quick summary again. So slit lamp by microscope, using the slit lamp is optional. You have to inspect first because there might be a contraindication for doing the test in case of acute dacryocystitis. Lateral traction is optional, but you have to place your finger below the medial palpebral ligament, observing the punctum, mainly the lower punctum, while pressing. The direction of pressure is upward, backward, and medially. Okay? And you have to document, is it positive or negative? If it is positive, you have to say the nature of fluid and from which punctum fluid is coming. While you are studying, please try to visualize more pictures, more illustrations, more schematic presentation. Sometimes some atlases have like photos from cadaveric eyes, okay? I know some people who are practicing, before practicing DCR, they did the surgery on cadaver before they operate on real patients. So you have to be familiar, especially DCR is one of the important surgeries that you have to know about the steps. How can you know the steps without knowing the anatomy, okay? Regurgitation test is part of lacrimal sac evaluation, and lacrimal sac evaluation is part of something called lacrimal drainage system evaluation. Mainly, we are talking about epiphora. And lacrimal drainage evaluation or epiphora workup is part of watery eye workup. So the patient will come to you with watery eye. The patient will not tell you, I have an epiphora or I have a problem in my drainage system. Those who are following my classes, or if you are studying or you already have the knowledge, watery eye is divided into two big categories. Can anyone remind us of the sub-classification of watery eye?
It could be either due to hypersecretion or due to blockage.
Yes. So the patient will not tell you, I have a oversecretion or I have lacrimation, excess lacrimation. No, you have to work up. You have a watery eye. You have to know, is it excess secretion, which is called lacrimation, or is it epiphora? So this is a big title. You have to know how to approach the patient with watery eye. Okay, so we're done with the first test. The second test is the fluorescein disappearance test. So what do we mean by dye here?
Fluorescent dye.
Okay, so fluorescein has many uses in ophthalmology, at least 10 uses. So this is one of its uses. And what do we mean by disappearance? Disappearance from where?
From the conjunctival sac.
Excellent, excellent. Okay. So can we use this test? Can we do this test using the fluorescein filtered paper?
Yes.
Have you ever done this test using fluorescein filter paper? I don't know, but in this video,
Fluorescent
what?
Fluorescent paper. Fluorescent paper that is wet with 1 drop of antibiotic. Then insert the drop is inserted into the conjunctival cul-de-sac.
Yeah, okay. So, but in this video, I'm using like prepared eye drop of fluorescein, okay?
Okay.
Because it should be like highly concentrated a little bit. So if I'm going to ask you what are the tools, so before you do a test, you have to know what are the requirements. So we need fluorescein, this is number one. What else?
Cobalt blue filter of the direct ophthalmoscope.
Yeah, this is an optional. Well, what else? It was in the video actually. We need a timer, okay? We need a timer.
Okay, time. Okay.
So just one drop in each eye consecutively. Because generally speaking, it's like a comparison test.
Yes.
So ignore what he is doing. I will explain what he's doing later on. You look for what? So you apply one drop and then what happened?
Then we'll wait for 5 minutes
Mhm.
and we look at the presence of fluorescent dye remaining in the sac. Usually it disappears after 5 minutes.
Yes, exactly. And sometimes
And
we
you
make,
can compare with the other eye.
yeah, and we make a comparison as well. So actually here I'm setting timer. So what I'm doing here?
Under cobalt blue filter.
Yes. And there are different options you can use from the direct or indirect ophthalmoscope. Okay. So just imagine this is after 6 minutes, let's say 6 minutes. So there is some remnant here. So now we call it positive test or negative test?
Negative test.
Any other answer? Any other answer? So we have still fluorescein in the conjunctival sac.
According to the remnant amount thickness.
Suppose this is like 7 minutes, 8 minutes, and still they have a significant amount of fluorescein in the conjunctival sac. So you are going to document this finding on the patient's file. Will you write positive test or negative test? This is my question.
Positive test that the dye is
Positive
still
test.
present.
Yeah, so positive test, because generally speaking in medicine, when we say positive test means abnormality, okay? So if you have an infection and you do lab and you find the virus markers or whatever, you have the positive test, you have positive illness, okay? You have the illness, you have the infection. So here this is called the positive fluorescein disappearance test, because you have to know how to document the finding as well. There is grading, there are much details regarding this test, and there is false negative, false positive, but we're not talking about this. If we have like significant amount of fluorescein after like 6, 7, 8 minutes, okay, this is called positive fluorescein disappearance test. And you have to know the implications. What does it mean? Okay.
Okay, thank you.
Here we added something. So whenever we use cobalt blue, in order to improve the visualization, we may use what? Or we may ask another person to what?
Switch off the light in the
Yeah, turn off the lights. Of course, like tear breakup time, or when you measure the intraocular pressure per Goldman applanation. In order to improve the visualization, you may dim the illumination. Okay. Again, here I ask the volunteer to stay away in order to visualize both eyes at the same time. Okay, and make a comparison. Of course, he doesn't have any problem, but we are just illustrating the test. So this is how I prepared the eye drops. So I take the remnants from, fluorescein is used in angiography. So I just washed the remnant of some ampules in order to prepare these eye drops. So the fluorescein angiography, we use 10%, but in fluorescein staining of conjunctiva and cornea, we can use like much, much lesser concentration, like 2% or even less than 2%. So the last question for you, before you answer this question, so do you have any comment on the way I wrote this question?
It's in red ink.
It's what? Alarming or?
Yeah, something.
Yes, it's something alarming. I use the red
Yeah,
against the
red ink.
dark black background. And this, by the way, this type of font is called the chiller. Okay. So which one is a slit lamp photo? Unless you raise the
The
white,
second one.
the right side. So don't say second
Yeah, right
first.
side.
I don't,
Right
yeah,
side. Right
you have
side.
to say
Right side.
according to the orientation of the slide. So in the right side.
Right
Okay.
side.
So I'm going to mute you. Thank you. Does anyone else have any other answer or another
I
answer?
think the left one.
Okay, so
The
someone,
left one, madam.
the left. Okay,
According to screen, the left one is the slight lamp.
so someone said the right and someone said the left. Actually, neither is a slit lamp photo. It's just an external photograph. Okay, so slit lamp photo should be taken using the optics of the slit lamp. It should be, I should place the mobile on the oculars of the slit lamp. So neither of these photos is slit lamp photo. It's just an external photograph, but the patient is sitting on the slit lamp. Okay, so this is the front view, and this is a profile view, and that's why I use this font, because it's like a trap, and you fell in the trap. Okay, got it? The patient is sitting on slit
Yes,
lamp, right? But the photo
yes,
is
yes.
not a slit lamp photo. It's a external photo. All right. So, and here from this reference, this child has a problem like watery eye on the right side. And it's, dye disappearance test is not invasive, and you can do it on in children, but you have to keep the child sitting upright. Okay. So along with the history, so the parents are complaining of watery on the right side, and you did this test and you find excess fluorescein on the same side mentioned by the parents. So this supported your diagnosis of, let's say, congenital nasolacrimal duct obstruction. So in the right side, we say we have positive fluorescein disappearance test or dye disappearance. And again, as you see this photo under the cobalt blue illumination, and we make a kind of comparison. Okay, this is according to the reference. And I brought this image from another source. Notice how the use of cobalt blue improves the visualization a lot. But here again, patient with history of watery eye on the left side. The examiner did fluorescein disappearance test and it shows positive test on the left side. Can you guess what it is? Why I asked my volunteer to do this maneuver, however, it didn't work. So can you guess what it is or what he was doing? Yeah, tell me.
To manually block the nasolacrimal duct to simulate
Yes.
the obstruction.
So I thought we can simulate nasolacrimal duct obstruction or any obstruction of the lacrimal passage, but it didn't work. However, we use this technique to what? Sometimes we ask the patient to do digital compression in some situation. So can you tell me
To
about
reduce
this?
the systemic absorption of the drug.
To reduce what?
Systemic absorption.
Yeah. So to decrease the systemic absorption and to decrease the incidence of side effects, and also
To increase the retention period of the drug.
Excellent, excellent. And we may use this technique in such a condition.
Madam, especially for glaucoma treatment,
Yes, excellent. Yeah. So fluorescein disappearance test, again, as a kind of
Ma'am, I have a query. Can I?
Yes, please.
Ma'am, so why was this maneuver done while doing a fluorescent dye disappearance test?
So I said, ignore this maneuver. I was trying to simulate obstruction of the lacrimal drainage system. So I wanted to demonstrate unequal disappearance of the fluorescein on my volunteer, but it didn't work. Okay.
Okay,
But
thank you.
if you are going to do the test, don't allow the patient to do any compression. Just apply the eye drops and wait for 5 minutes and then see. Okay.
Yeah.
Ma'am, I also have one query.
Mhm.
What is the percentage of fluorescein we need for this FTTT?
So according to the reference, whenever we use fluorescein dye on the ocular surface, so we can use up to 2%, but we may start from 0.12.
Okay,
Let's see.
right now. Thank you.
Ma'am, do we tell in the exam it is a fluorescein strip with this one drop, or with the dye, means as you have prepared like that dye only? Because here we use only the strip. We don't have the access to.
So, but you have like fluorescein angiography, right, in your institution.
Yeah.
So you can do what I did, because the concentration of fluorescein in ampules is 10%. Fluorescein angiography. Fluorescein fundus angiography. The concentration is 10%. Okay. So,
Sometimes we use 20% also.
okay. The ampule itself is 20%.
20%, 3 ml of 20%, or I guess 5 ml of 10%.
So even if we have just one drop from this ampule, we can create many ampules, many eye drops. Okay. So we need from 0.12 to 2%. No need to use more than 2% when you are staining the ocular surface. So once more, if we have a fluorescein dye disappearance test and there is no fluorescein, I need someone to volunteer here.
Yeah.
So if we have fluorescein dye disappearance test and there is no fluorescein in the conjunctival sac after 5 minutes, is it positive? And this is normal, okay? Is it positive test or negative test?
It is negative test.
Excellent, negative test. I'm trying to confuse you. So it's negative. So negative here, I wrote it in a green background because this is normal. Okay, stay with me because I'm going to confuse you right now. Once more. Can you name this test?
John's dye test.
Why you said this? It's the same. We apply fluorescein on the conjunctival sac. It's the same. What's the difference?
That we are checking for the staining in the inferior through the nose.
Yeah. So just a little change in the steps makes another test. And you said Jones what?
John's dye test.
We have 2 types of Jones. Which one?
Yeah,
This.
John's 1 and John's 2 are there. This is John's 1.
Okay, excellent. So the only difference between fluorescein dye disappearance test and Jones 1 that we are looking for the fluorescein in the nose. Okay, we are trying to see whether there is fluorescein in the nose or not. All right, so this is Jones 1. Here, if we have fluorescein in the nose, this is normal, right? As in this case, we have fluorescein on the Q-tip here. Okay. Is it positive or negative test?
It's positive.
Excellent. Excellent. So this is a kind of irony to what I said before. When it comes to Jones 1, if we say positive, it means normal. It means the fluorescein passed through the passages freely until we retrieved it from the nose. So please don't confuse between how to document dye disappearance test and how do you document Jones 1, because they are opposite to each other. Okay? So one last question. Suppose this is the right side is normal. There is no issue in the lacrimal drainage system. You apply fluorescein and it disappeared from the conjunctival sac. This is called what?
Yes, ma'am. So after a minute, the dye disappeared.
After 5 minutes, the dye
Yeah.
disappeared from the conjunctival sac. So we call it now, how you can document this information?
Fluorescent dye disappearance test would be negative.
Negative. On the same patient, you were able to retrieve fluorescein from the nose. Name the test, and is it positive or
It is John's dye test 1, positive.
positive? So in this patient, we can say it's a fluorescein disappearance test negative and Jones 1 positive on the right side. Got it?
Yes, ma'am.
So you have to know how to evaluate the lacrimal drainage system. Nothing fancy about this slide because it was taken from Kanisky. So you have to know the history, points to be asked in the history, examination, start by inspection, palpation, special test, and investigations. The next test is the examination of the lacrimal. So in the exam, you are going to speak. So speak right now before you speak in the exam. Why you are shy? Yes.
Yes.
Elaborate on what's written on the slide.
Right. So when we're inspecting generally, firstly, we want to focus our attention on the area of the lacrimal gland. That would be the supratemporal aspects of the orbit. And particularly, we want to check the positioning of the eyelid, any notching or anything. And we want to see if there is an S-shaped deformity of the eyelid.
And
Then,
how about the other points, dystopia and
right.
proptosis?
Right. If there is any deformity of the lacrimal gland, that would typically push the globe downwards and outwards. So we want to check for dystopia.
Wait. Push the globe what?
It would push the globe, the eyeball, downwards and outwards.
Outward?
And
Yes,
inward.
proptosis.
And inward.
Inward.
Yes.
Inward. Okay, just
Downward
imagine.
and inward.
Yes, just imagine the lacrimal gland is the upper outer. So to push to the opposite side, to push the globe to the opposite side, downward and inward. Okay? Got it?
Okay.
So,
right.
And usually lacrimal glands swell, like tumors, cause dystopia more than proptosis.
Right. Agreed. Yes.
And whenever we have a dystopia, you have to mention the position. Is it inferior? Is it superior? Is it nasal? Is it temporal?
Yes.
Or
In relation to the other normal side, we make measurements in comparison with the other normal side. Yes.
All right.
Right. So you're starting to palpate whether the lacrimal gland itself is palpable.
So I'm trying to insinuate. So try to use this verb, insinuate my finger, okay, behind the upper outer angle of the orbital margin in order to palpate the lacrimal gland, the main lacrimal gland. Okay?
Right.
Palpation.
Now
So generally speaking, the main lacrimal gland should not be palpable. It's not palpable. Okay? You can't palpate it because normally it is not palpable. If you feel a mass in this area, there is something wrong with the lacrimal gland. Could be inflammation, could be tumor. Okay, so normally, right now, try on yourself or try on elderly or whatever volunteer you have. Normally, it is not felt. Also, you have to notice if there is any tenderness while palpating the main lacrimal gland. Palpation of the regional lymph nodes is also relevant in case of swelling of the main lacrimal gland. And now, what am I doing?
You are exposing by lifting the upper lid upwards to check whether it's visible when you remove the covering effect of the upper lid.
Actually, I did two things. I retracted the lateral part of the upper lid and I asked the patient to look
To
at the
look down.
opposite direction, okay, down and inward,
Right.
okay,
Right.
in order to see if there is any visible, like any visible part of the lacrimal gland. We usually talk here about which part of the lacrimal gland, because we have two parts of the lacrimal gland.
Yes, the palpebral and the orbital. So right now, if anything would be visible, it would be the palpebral.
Okay. Here, sometimes, normally, especially in elderly or patient with elderly or with some involutional changes, you may see the palpebral part, okay? So if you see the palpebral part, this is a normal finding in elderly. Got it?
Yes.
So normally it is not seen, but sometimes you may see prolapsed or ptotic palpebral part in elderly. And you have to do the same on the other side. Retract the lateral part of the upper lid and ask patient to look down and in. Okay, so again, here's a schematic representation of the lacrimal gland. You have the orbital part, and this part belongs to the orbit. Okay, it's hidden in the orbit. It's hidden behind the orbital rim.
Yes.
You can't palpate it, okay? And we have palpebral part, which is part of the anatomy of the eyelid. And there is something divide, or like there is a structure here, an important structure between both parts. What this structure? You see it? Let's enlarge it.
The orbital septum.
No. This
No.
one. No. Okay, this one. There is an important structure here that somehow separates the orbital part from the palpebral part.
It's lateral palpebral superior aponeuris.
Yeah, excellent. So just a reminder, we are here to share information. We are not showing off our knowledge. So it's okay to correct each other or to help each other. It's kind of helping. Yeah, so it's not enough to say levator. You have to say aponeurosis, because levator is a big muscle and it has many parts. I'm not going to ask you what is the origin or the insertion, but it's a very long muscle. It has many insertions. So once again, do you see the marker here? This is the orbital part, okay? And this is the orbital part, and then we have the palpebral part, and we have the ducts coming from the palpebral part, and we have the aponeurosis of the levator palpebral superior muscle separate the two parts. What is the implication, or what is the importance of knowing, or why I'm saying the aponeurosis? What is the significance of knowing this information? Sometimes basics anatomy is important when it has some correlation with the clinical or the surgical, like it has some surgical implications. So what is the importance of knowing that the levator aponeurosis laterally here somehow separates orbital from palpebral? Because what? You may, what is the importance of the anatomy of aponeurosis in this area? Because in ptosis surgery, you may injure the the palpebral part, because this is very close to the aponeurosis. Okay, this is one of the complications of ptosis surgery. All right, so you have to familiarize yourself with the swelling. If you have a fullness in the upper outer part, what are the causes? So for example, this from a reference, we have an S-shaped deformity, but this is not due to lacrimal gland problem. According to the reference, this patient has what? Neurofibromatosis type 1, and neurofibroma on the eyelid that caused this S-shaped deformity. Fullness in this area may be due to something in the eyelid or maybe something in the lacrimal gland. All right? And this is an example of just a simple case of dermatochalasis, because sometimes it's not symmetrical. So you may see excess fullness here. So you have to know how to differentiate between different causes. Again, this is eyelid problem, not lacrimal gland problem. The same also applies to blepharochalasis. So you have to differentiate between dermatochalasis and blepharochalasis. Here another example, but here due to lacrimal gland prolapse. So there is something called prolapse of the orbital part, the orbital loop, not only the palpebral, no, the orbital also, according, this is from Wikipedia. So this patient turned out to have prolapse of the orbital loop. Again, there's fullness on the lateral part here.
Ma'am, one query. If external angular dermoid can cause a S-shaped ptosis,
we can say fullness. Okay, so S-shaped deformity is not pathognomonic. Okay, this is not a pathognomonic sign for a lesion. It could be a lacrimal gland issue. It could be eyelid issue. The eyelid maybe neurofibroma or maybe other swelling. So it's not pathognomonic of anything. Okay, it's just a descriptive term. Good that you remind me of the dermoid, because sometimes we have external angular dermoid or internal angular dermoid. So you have to make your own list of the differential diagnosis of any swelling according to the location. What are the cause of swelling here? What are the cause of swelling here? This is example of lacrimal gland tumors in an old lady. I brought this because to show you how the profile view is important. So you can see here, the swelling takes actually the shape of the lacrimal gland. So this is front view and this is profile view. And you have to see if there is dystopia or not in such case. So in this photo, this is according to the reference, also a lacrimal gland tumor. Here, it seems to me that there is some kind of proptosis here. There is some fullness here. You see fullness? There is fullness here.
Yes.
Okay.
Yes.
And this eye looks bigger because I said before, when you have a proptosis, the palpebral fissure may get bigger. So my question to you, because we covered again proptosis before, if I need to confirm the presence of proptosis, what shall I do?
You assess proptosis by checking measurements with either a Hertel exophthalmometer.
Something before measurements, before using exophthalmometer, before using ruler or whatever, to have an idea.
Worm's view.
Yes. So yeah, by inspection, use Worm's view or Navziger view. I prefer Worm's view. It gives you some idea that one eye is preceding the other. And then you mention measurements. Okay, so don't forget Worm's view because it's very, very helpful whether the case is you suspect proptosis or you suspect enophthalmos. Worm's view is very helpful.
Right.
Right, okay. Here, the learned lesson, you have to revise the causes of swelling on the lateral outer part of the orbit. You have to revise the cause of the swelling on the upper inner part, okay? You have to revise what are the causes of lacrimal gland enlargement. You have to study lacrimal gland tumors. You need to study and how to evaluate proptosis and dystopia. Here is some photos about visible part of the lacrimal gland. So according to this reference, the palpebral part is visible. Okay, you will see lobulated. It's not just only conjunctiva, like the conjunctiva, but something yellowish, whitish, lobulated behind it. Okay, and as you see, two instructions. You retract the lateral part of the upper eyelid and you ask the patient to look down and in. Again, differential diagnosis for visible mass here. It could be prolapsed or ptotic palpebral loop. It could be something like this, what we call it this.
dermolipoma.
Dermolipoma or lipodermoma. And it could be something like this, what we call this.
Orbital fat prolapse.
Say it again, please.
Orbital fat prolapse.
Yeah, orbital fat, and it's very yellowish, okay? By the way, dermolipoma and prolapse or orbital fat, they both have fat, but you have to study how to differentiate between both. In all these photos, they all have the common theme, the same finding, visible mass or visible swelling in the lateral outer part from the conjunctival side or in the lateral canthal area, let's say. Sometimes there is inflammation of the lacrimal gland, so you may say inflamed the palpebral lobe according to this reference. So here I brought this image because sometimes the profile view is very helpful. So let's summarize. You may have an idea about the protrusion of the globe from the profile view. Is it ophthalmic or proptotic? And sometimes if we have like severe keratoconus, you can appreciate this from the profile view. From the profile view also, you can see the coaptation and the alignment of the lid margin and the direction of the eyelashes, upper and lower. From the profile view, you can appreciate any fullness in the lacrimal gland area. The final slide here regarding lacrimal gland evaluation, it's part of the differential diagnosis of swellings in the upper outer quadrant of the orbit. The next test, why I mentioned upper eyelid eversion, why I didn't mention or about lower, it's a silly question.
Because upper lid eversion is a technique which we have to master, because the lower lid is like, if we retract the lower lid, we can visualize the tarsal conjunctiva and the fornix, but for the upper lid we need to evert and visualize the tarsal conjunctiva.
So this is not a valid to say eversion of the lower lid. The lower lid doesn't need eversion, it's just retraction, okay? By simple retraction of the lower lid, you can examine the lower palpebral conjunctiva and lower fornix at the same time.
Same time, yes.
So I'm going to explain this part. Here I'm explaining the mechanics for upper eyelid eversion. So I'm using the analogy of this agenda because it has like a tough cover. So the eyelid, the same, has a tough structure, which is the tarsus, okay? So the agenda has a tough cover, like the eyelid. The eyelid has a like tough structure. This the supportive, the skeleton of the eyelid is the tarsus.
Yes.
All right. So normally when you are looking straight ahead, this area from here to here is the globe, the exposed palpebral fissure, okay? And this blue part is the eyelid. In order to avert the upper eyelid, you need to use both hands, okay? You hold the lid margin from the eyelashes, and you need the other hand to act as a support, as a fulcrum.
Yes.
If you place the fulcrum or the support at the middle of the eyelid, you wouldn't be able to avert the upper eyelid. You can't kink, you can't kink the tarsus because it's tough, okay? So your support should be here at the upper border of the tarsus, not in the middle of the tarsus. Because the tough structure, you have to place the fulcrum or the second finger or at the upper border of the tarsus. At the upper border of the tarsus, here. So you put your finger as a upper border of the tarsus as support and avert by the other hand, by holding the lid margin. One last thing. Normally, the patient is looking straight ahead. The upper eyelid is not relaxed. It's like the upper part of the tarsus is hidden backward. Okay, so you need to give the patient or the volunteer here some instruction. You have to ask him to look down. What's the importance of looking down?
It will help to relax the
muscles. So all the muscles are relaxed. So the levator and orbicularis are relaxed. Okay, so there is a complete relaxation. Plus, you can easily put your finger on the upper border of the tarsus. So by asking the patient to look down, you can easily apply your finger or your support on the upper border of the tarsus. Plus, the patient is fully relaxed. Now explain, Dr.
Yes, so the patient is looking down, and with the right hand, we have to hold the lid margin of the patient. With the other hand, we have to with the other finger, we have to use as a fulcrum on the upper border of the tarsal plate, and gently evert the eye.
Yes. So now you successfully everted the upper eyelid. Don't forget to examine the upper eyelid. So you need to provide like a light source to examine the conjunctiva. Usually we do it on slit lamp actually, because most of the signs are very subtle for papilla, follicles, membranes, lines, scars, foreign body. So usually we do this on slit lamp. Okay. What is the last step?
Last step is to gently leave the to revert it back to its position.
Yeah,
So
so turn it
we
back
have
to
to,
the by yourself. By yourself, you
yes,
have to
we have
return
to
the eyelid
to
gently.
the position.
Yeah,
Mm.
because if you leave the patient while the eyelid is
Yeah,
everted,
it will remain. Yeah, it will remain like that, and it will be very uncomfortable for the patient. And then when he blinks, it might come, but it will be very uncomfortable, and it is not right.
yes, if you leave it,
Mm.
it would be very uncomfortable for the patient with the blink. Definitely,
Yes,
he will blink, and it might cause severe pain actually. So
okay, yes,
as you see, you
we
have
have to
to gently return everything
revert it
to its place. Okay,
position. Yes,
and you have to
yeah,
do the same on the other side.
yes.
Actually, I can evert my eyelid by myself. So yeah, you can practice on yourself. All right, and then I'm showing what right now, something called double eversion. So only eversion, you can see what the upper dorsal conjunctiva. But if you want
Yes.
to check what, you need double eversion.
The fornix, the upper fornix.
And can you do it alone? I mean, can you do it just by your hands, or you need something?
We need the everter. I don't remember.
It has
I
a
don't
name.
remember. Yeah. Uh, I don't remember the name.
But it's a smart answer. We need everter.
Yeah, but I don't remember. I'll try to remember. No.
So anyone can help her with
Desma is lid retractor.
Desmet. Yeah, Desma is lid retractor.
yeah, Demar retractor. So it's a retractor. Forget the name of the scientist. Definitely he passed away, but now it's the same technique. Yeah, same technique, but you are forcibly, apply the as shown on the video. So because it's very uncomfortable, so I asked my volunteer, "Are you sure that I can do it?" But he gave me consent, so I did it. So we usually use this on some surgeries. So do you remember one of the surgeries that we need to do this technique? An eyelid surgery that we need
May I?
to, yeah. Mhm.
It's molar conjunct.
Yes. But you have to say the full name.
Conjunctiva molectomy, madam.
Yes, excellent. So this is here we are talking about surgery, but in clinical practice we need double eversion if the patient has there is some abnormalities that we need to check the fornix. All right. Another volunteer who is photographing now on the right side, you can see here the upper fornix nicely. You can see the upper fornix and also a greater extent of the upper bulbar conjunctiva. Here. Sometimes we have a pathology in this area. Do you remember any pathology that it has a name similar to the name of the fornix?
Giant fornix syndrome.
Yes, giant fornix syndrome. This is one thing, although rare. Or sometimes if the patient is like contact lens wearer and there is a slipped contact lens, it may be lodged here in the fornix. So you may need double eversion to retrieve the lens. Excellent. Well done.
Also in chemical injuries, ma'am, we have to
double
Yeah,
divided.
if there is some debris, yeah, you have to remove it. Excellent. In general, we use it while the patient is lying flat, so in order to better visualize the upper fornix. Because as you see, in order to see it, the cameraman actually is like sitting on his knees in order to give us this view from down. See, he was like sitting here, the cameraman.
Madam, I have a question. May I?
1 second. So here on the slit lamp, you can do the, we usually do the upper eyelid eversion on the slit lamp. Yes, say it, doctor, fire away.
Do we have to apply anesthesia or no before
No,
doing this maneuver?
no. You can do it on yourself, by the way. It's not that,
Discomfortable?
yeah, it's very easy. But you have to be relaxed, okay? If you have a
Okay.
patient who is like squeezing his eyes, you will never do eversion at all, even if applying like many drops of topical anesthetics, eye drops.
Okay, thank you.
So again, you can use the Q-tip applicator instead of your finger. It doesn't really matter. Sometimes here, I forgot to mention this. We usually hold the lid margin from the eyelashes. Okay, so try to be gentle. There is no need to, epilate a lot of eyelashes while doing the test. And sometimes you apply a little bit of stretch downward before you evert. Okay, so you ask the patient to look down and you hold the lid margin from the eyelashes with a little bit of stretch, downward stretch. And use this as a fulcrum and then evert. And examine, of course. And the final step is to return the eyelid by yourself to its normal position. So I need someone to volunteer. It's very easy. This photo is actually, we demonstrate to undergraduate medical students. So I need someone to comment on this photo. This is an example of how eyelid eversion is very helpful. You may miss a sign if you didn't evert the upper eyelid in a patient. I need someone new. I can see you all, but I don't want to pick someone.
I can. Yes, ma'am.
Yes, finally. Okay, so give me the signs.
I can see large papilla.
So we have,
And
large localized papilla here. Excellent. Okay.
and some
So
mucoid discharge.
I can't see mucoid discharge, but this is not follicles. So usually when you have something huge like this, although the photo is not focused, usually we say it papilla. When we have like a big, very big papilla, we can call it what?
Giant papilla.
Macro papilla.
Yeah, macro is okay, but giant is more.
Giant papilla.
I wanted giant papilla. Okay, so do you remember this dimension of giant papilla? The size?
More than 1 millimeter. More than 1 millimeter, giant papillae.
Okay, giant papillae more than 1 millimeter. So is there any other sign, like significant sign on this photo?
Severe conjunctival injection.
Okay.
You can say hyperemia.
So you see the examiner is still not satisfied. Remember, one of the tricks, if the examiner is not satisfied, there is another sign, and there is an important sign, and you have to answer it, okay? So don't lose face. If the case is like an OSCE, you have to re-examine again. Try to be systematic in your examination. Try to examine every structure in systematic approach. If it is viva and you have a photo, you have to look again, scrutinize the photo, look carefully. There might be another sign. Now I enlarged the photo for you. If you are sitting away from the patient, stay closer to the patient. You may elicit more signs if you come closer to the patient. So I enlarged the photo for you to try to find another sign.
There's contact lens.
Yes, this is a contact lens here. All right. Can you name the type of this contact lens? It's very hard to name it because you can't touch it, but at least you may have an idea. Is it soft or hard?
I don't think it's soft
Yeah, why you said this?
because I saw soft before, but hard I didn't see before.
So what's the difference between hard and soft? So usually the hard contact lens is smaller in size, okay? So this, you see, here the contact lens is smaller than the cornea. It's smaller than the cornea, okay? And giant papillae as a complication is more with hard contact lenses. So actually the key answer for this slide is the giant papillary reaction or complications of contact lens, hard contact lens. You have to try to study what could be the possible signs on the conjunctiva, what are the cause of follicular conjunctivitis, what are the cause of papilla, other signs on the conjunctiva like membranes, scars. All right?
Should I enumerate now?
No. Write it down on your study note. I have to revise this. I have to revise that. Okay? So here, as you see, just eversion, you can see the tarsal. But double eversion, you can appreciate the larger extent and also the fornix. But there is something called retraction of the upper lid. By retracting the upper eyelid, you can see the superior limbus, the upper bulbar conjunctiva only. Okay, by retraction of the upper eyelid, you can see only the upper part of the cornea, the superior limbus, and the upper bulbar conjunctiva. By manually retracting the lower lid, you can see the tarsal conjunctiva and the fornix at once. The last point here, vital stains. I will talk about it quickly because we covered this before. But I was happy to get the lissamine green and rose bengal, so I want to share it with you in a video. So all are in filter papers. This is a fluorescein. And this is lissamine green. I talked about this before in a previous class. And the rose one is the rose bengal. I demonstrated only rose bengal staining because it has additional benefits I talked about before. But if I am going to ask you which one is mandatory to instill anesthetic eye drops?
Rose bengal, more irritant.
Yes, because it's very irritant, so you have to apply anesthetic eye drops. And whatever you are using, because filter paper is a tough paper, and some patient has like fragile epithelium, you have to moisten the paper with an eye drop, like to make it like gentle or to make it like moist. So as you can see here, I added also 1 drop of anesthetic eye drops on the filter paper itself. So the irritant stain is rose bengal. Okay, the irritant stain is rose bengal. But fluorescein and lissamine green, you can apply directly on the globe. There is no need to instill anesthetic eye drops before. And we usually touch the lower pulpar conjunctiva. It's less sensitive than any other part. Okay, so this is an old slide. Fluorescein, generally speaking, 2%. Rose bengal is 1%.
Lissamine green, 1%.
So which one in order to improve the visualization, we dim the light? Fluorescein. Dimming the light or turn off the lights really help to improve the visualization when you are using fluorescein. And with fluorescein, we need to use the cobalt blue filter. But other stains, we can use the yellow lighting, the standard light. There is no need for any filter. We finished the clinical test finally. So the next part is cases. So although this is a clinical mock practice, but I also incorporated some cases of questions asked in the Viva. This is from Bangalore. So last year, earlier in
Yes, ma'am.
February. Can you read aloud this scenario?
A 50-year-old man with unilateral watering of the left eye. Approach, written scenario, no photo.
Okay, so remember what I said earlier during this class, anticipation is one of the keys to success. So usually in Viva, they may give you a photo, they may give you a written scenario, like a clinical problem, like very short clinical problems with some keywords in just one line. The examiner may read it out from a piece of paper, or maybe just an open question, tell me about blah, 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 okay? So this is different ways how they ask you in the Viva. So this is like a short written scenario. Tell me about the keywords here.
50-year-old.
So the age is important.
Yeah.
And you have to say years, okay? Year. What else?
Male patient.
Sometimes gender is relevant, okay? Sometimes.
Unilateral watering.
Okay, so the most important key factor here, keyword is watering. We have watering. So watering, and you have to mention the side, of course. And remember, even if the condition is unilateral, you may need to tell the examiner that I need to check the other side. Okay, if there is time, just show the examiner that you are careful and you have to examine the other side. So now try to make some correlation. We have an oculoplastic station.
Yeah.
Okay, and we have watery eye.
Mm.
And you know that watery could be lacrimation, excess production, or epiphora. So do you think this case is all about what?
It is
Epiphora. Usually it is epiphora because
yeah.
lacrimation due to cornea or conjunctival problems, and why they bring such a case in oculoplastic stations. So you have sometimes the name of the station helps you to predict the diagnosis. Okay? All right. So can you read aloud?
History.
Yeah, he started by saying history. So quickly mention the importance of history and some relevant questions whenever we have a watery eye, okay? And focus on the causes of epiphora because this is an oculoplastic station. Keep going, differentiating.
And differentiating between paradoxical watering and drainage issue.
1 second. So I think the candidate mean here by paradoxical watering, lacrimation.
I started with inspection for facial asymmetry. He then proceeded to ask me about anything specific on inspection.
Okay, so sometimes the examiner might cut you off and try to say, no, it's enough about history, it's enough about general inspection, try to focus on the area, try to give me some specific, points. Again, so you mentioned at first, it's very good to show the examiner that you know that watery eye could be due to lacrimation or epiphora, okay? This is very good, good starter, okay? But now you have to focus on epiphora. So do you remember the classification? I mentioned before the classification of epiphora. Sometimes we can classify it into two big parts. Something called obstructive and non-obstructive epiphora. Do you remember this? If we have like facial nerve palsy, with ectropion of the lower eyelid, the lower punct is away from the lacus lacrimalis. So this is a kind of epiphora, but non-obstructive.
Yes.
Okay. And also in facial nerve palsy, there is affection of the lacrimal pump because lacrimal pump depends on muscle called the horner muscle, which is part of the orbicularis, which is supplied by the facial nerve. So in facial nerve palsy, we have watery eye. We call it non-obstructive epiphora. Okay. Actually, the candidate started by saying this. But again, we usually ask about facial nerve palsy in neurostation, not in oculoplastic station. So usually when we have a watery eye on oculoplastic station, we usually mean epiphora, and we usually mean obstructive epiphora. Okay, so read what the candidate mentioned. I replied by saying what?
Long-standing facial nerve palsy with a cicatricial ectropion.
Do you have any comment on this line?
Facial nerve palsy producing cicatricial ectropion. It's paralytic ectropion. No?
Yeah, it's paralytic. So facial nerve palsy causes paralytic ectropion, but sometimes due to
watering,
the eczema,
watering can cause atopy of the
affection of the skin and added an extra layer of cicatrization. But generally speaking, you have to say facial nerve causes paralytic ectropion, not cicatricial. But still, the examiner wasn't happy. Okay, although what he said, the candidate, what he said was correct. Still, the examiner was waiting for something more specific. Again, think again. Watery eye, oculoplastic station. We are talking about epiphora. We are talking about obstructive epiphora. So, what are the relevant points on inspection? Can you say it?
Inspection, ma'am.
Yeah.
Lower lid margin.
Yeah, the candidate already mentioned the lower lid margin for ectropions. He already mentioned this. What other point in inspection?
Lid laxity.
Again, lid laxity. In the same line with ectropion. Yeah, punctum started by punctum. Inspect the punctum. Okay, and what else? If you have a swelling of the lacrimal sac, is it relevant to this case?
Yes.
Yeah, it could be relevant. Swelling of the lacrimal sac. Okay. Now the examiner was asked specifically about some tests that you may use in evaluation in case of a watery eye, or let's say epiphora. So what are the specific special tests?
For the lid laxity, the snapback test.
So why you are focusing on snapback test? I don't know why. Yeah, it's good, but we have other tests related to epiphora, like more specific to epiphora. Lid laxity and ectropion. The candidate already mentioned this. Okay, the candidate already mentioned this. We already discussed the test, simple test at the beginning of this class.
Okay, the regurgitation test.
Yes. What else?
Fluorescent dye disappearance test.
Yes, excellent. What else?
John's test.
Yeah, excellent. Yeah, now we are starting to recall the information. So you are remembering everything now. What else? It's written in Kanesky very well. This the tests related to the epiphora. So the candidate actually mentioned the fluorescence appearance test, which is non-invasive. He mentioned also searing. Yeah, it's written in Kanesky under the heading of lacrimal irrigation test, soft stop and hard stop, and also there is John testing. Here the examiner is waiting for your answer. The examiner was asking, give me a less invasive, and the examiner showed him, he gave him a clue actually, a pressing motion with his thumb. So the examiner was very helpful. The examiner was waiting for ROPLAS or regurgitation test. He smiled and nodded. So actually, this scenario isn't complete because there is a lot of time wasted in saying correct information, but not specific, okay? But imagine another scenario. If the candidate had mentioned regurgitation test and fluorescein disappearance test and relevant point earlier, usually the examiner will add another follow-up questions like management and other things. So you have to, while you are studying the experience, you have to reflect on the experience and try to learn some lessons from it. Okay, and be aware of some spelling mistake. Oh, sorry, some mistakes, some typo.
Ma'am, actually, I was means in my this thing, I was thinking of the entropion, so I was going with that entropion. That's why I started with the lid laxity in everything. So now I
Yeah.
remember it is only meant the watering in one eye. There is no nothing told about the lid laxity. Yeah, that's true.
Yeah, it could be a possibility also, because if we have an entropion or ectropion, we have also kind of irritation and lacrimation. Yeah. Plus in paralytic ectropion, we have actually epiphora. Okay. But you have to look at the big pictures. So when you said laxity, I didn't say it's wrong. I just said what else. Okay. So if you remember when you are studying epiphora from Kanisky, you will find they have to evaluate the lid margin, one of the points to be assessed. Okay. So learned lessons and you have to study. I shared this before. Watery eye could be lacrimation or epiphora. Epiphora could be non-obstructive or obstructive. And sometimes we have a combination of all of these. The second experience.
Photo is showing a large SCC, squamous cell carcinoma, involving part of lid and large part of temporal aspect of lateral campus.
1 second.
Describe.
1 second. This is from Viva. So here's the station. Started with a photo. Okay. Do you have any comment? How the candidate knows that this is squamous cell carcinoma? Does squamous cell carcinoma have like a pathognomonic features? No. In order to diagnose something like this, you have to have the histopathology. So I believe that it was like an ulcerative lesion. And whenever you have an ulcerative lesion, you may say basal cell carcinoma and then squamous cell carcinoma. This is my comment on this experience. I shared this experience because it's really important to study these malignant tumors very well, basal cell carcinoma, squamous cell carcinoma, okay? And how do you do biopsy, how to reconstruct the eyelid, and it's written very well in Kanisky. And pay attention to the description. So the simplest thing you can do at the beginning is to describe the photo, okay? Unless the photo shows a pathognomonic features. So suppose the photo shows pterygium. So instead of wasting the time by saying this is a fibrovascular tissue approaching the cornea, has an apex, no, you can start your answer by saying this photo shows pathognomonic feature of pterygium. The examiner might be satisfied at this point and shift to the next follow-up questions. Okay, so if you have a pathognomonic lesion, start your answer by saying the lesion, by saying the diagnosis immediately, because this is a single diagnosis answer. But if you don't know the lesion, or the lesion is confusing and it carries a lot of differential, you may start by describing the photo, okay? And that's why you have to pay attention while you are studying the description of any tumor. Like in basal cell carcinoma, you will find nodular ulcers, telangiectasia, induration, non-healing ulcer. So you have to study how do you describe a lesion. Because in Kanisky, if you look at the photo, you will find below the photo, the comment, just a diagnosis. There's no description. How can you find the description of the photo? In the text. You have to read the text meticulously. All right? So the other one is another photo of Calision. Calision is, generally speaking, a pathognomonic lesion. All right? But even though the examiner asked about the differential. So do you know what is the differential of Calision?
Yeah, so Calision, the pathology.
What is the other name for Calision? What is the other name for Calision? So see, Calision is very simple. It's very common case in our practice. So sometimes we underestimate the value of a disorder. And then we face a question about it in the exam. And we answer it poorly, unfortunately. So Calision is very simple. It's like a gift question. It's like a gift. So what is the other name of Calision? What is the pathology of Calision?
Meibomian cyst.
Yeah, meibomian cyst, obstruction of the opening. And we have collection of whatever is the fat, and we have meibomian cyst. So you may think about a pathology that affects the meibomian glands. So what is the other red flag lesion that might arise from the meibomian gland other than Calision? Like quite dangerous.
Could be
If you have like,
Could be a sebaceous cell carcinoma.
yes, sebaceous cell carcinoma, especially if we have like recurrent Calesian, non-healing, you may think of sebaceous gland carcinoma.
Yes.
Okay. And it's more common in the upper lid or the lower lid? Sebaceous cell carcinoma.
It is more common in the upper eyelid
Why?
because the meibomian glands are more in number in the upper tarsal plate.
Yes, excellent.
I mean, yeah.
So can read aloud this paragraph. It's about this question, the squamous cell carcinoma.
Yeah.
Can you read it?
So squamous cell carcinoma, the clinical types of carcinoma are variable and there are no pathognomic characteristics. The tumor may be clinically indistinguishable from a basal cell carcinoma,
Wait a
but
second.
usually it does.
Yeah, 1 second. So it doesn't have pathognomonic features. Okay, so if you have an ulcerative lesion, like huge lesion, ulcerative, okay, so you are going to mention a differential diagnosis. Start with basal cell carcinoma. This is because this is the most common malignant tumor of the eyelid. Okay, so I remember I was a junior and we have like a case, all right. The case had like a lesion similar, exactly like 100% similar to a photo in Kanetsky about squamous cell carcinoma. So I told my senior this is a squamous cell carcinoma by clinical examination. He said, no, you have to mention basal cell carcinoma in your differential at first because the common is common. And the final word is for the histopathology in the end. So I know there is some table that differentiate between basal cell carcinoma and squamous cell carcinoma, but there is some overlapping between both. Okay. So can you continue?
Yes.
But
Yeah.
usually,
So, but usually it does not have superficial vascularization. It grows more rapidly and hyperkeratosis is more frequent. The nodular squamous cell carcinoma is characterized by a hyperkeratotic nodule that may develop with the presence of crusts and fissures. The ulcerating squamous cell carcinoma has a red base with well-defined, hardened, and everted edges. The histopathologic features of squamous cell carcinoma depends on the degree of differentiation of the tumor.
so yeah, so I remember when I was a medical student, usually I say basal cell carcinoma has inverted edges, squamous cell carcinoma has everted edges, but sometimes it's very hard to judge. Okay, so the message here, the takeaway message here, whenever you study a lesion, because the eyelid chapter is full of lesions and full of masses, you have to see if the lesion has a pathognomonic features, like a single diagnosis, or the lesion might has like other differential. It might be confused with other lesions, okay? It's really important.
Yes, ma'am.
The next, so
Yes, ma'am.
simply, like quickly, by inspection here, mention the
This is
signs.
this is facial photograph of a child which shows there is apparent an ophthalmos of the left eye with possible phthisis in the left eye.
Okay, so by the way, this is an experience from the OSCE. Okay, now we are talking about cases from clinical stations, from the oculoplastic station. As you can see, station 2, oculoplasty and eyelids. Okay, why you said possible? It's like, it's definitely an atrophy. Or I don't think there is much difference in the management between atrophy and phthisis. Do you think there is a vision here?
No, ma'am, I
So
don't think.
you can say most probably this is
It
no
is
PL. Yeah.
no PL. Okay.
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 Here I brought this image that may be similar to the real case. I don't know. I wasn't the candidate. But here the candidate wrote a young girl. Being young is relevant. What's the difference between having like atrophic globe in child and having atrophic globe in an adult? What's the difference?
If the child is still growing and there should be adequate volume of the globe for the orbital bones also to grow.
Yes,
So if there
excellent.
is the atrophic physical eye in childhood, there wouldn't be adequate growth of the orbit and there would be loss of volume in the orbit.
Excellent.
This is
Excellent.
important when it comes for reconstruction.
Excellent. All right. So this is actually the experience of Dr. Verma, who is an oculoplastic surgeon. So examine and mention the findings. Let's see what he said or what he wrote. Can you read it? ptosis?
Ptosis in the left with ophthalmos.
So actually,
Left eye.
this is his words,
Mm,
but this is not the
mm,
case. Okay, this is I brought this image from Google, but
mm.
is it common to have like ptosis with sisos?
Yes, it is because of the ophthalmos. There would be a drooping of the lid because there's no support of the globe, so there would be
Excellent. So
drooping.
whenever we have ophthalmos, so the upper eyelid will descend lower, and the lower eyelid might come upper actually.
Yes.
And he
Then
mentioned,
left eye corneal scar with membrane in the pupillary area.
so it seems that the scar is not that dense or not. He appreciated some membrane in the pupillary area. Okay, and I like this line. The right eye
Right eye
is.
normal.
This is very
Yes.
important because if we
Yes.
have a single-eyed patient, like one-eyed patient, you have to pay a lot of attention to the other eye. You have to protect the other eye.
Commented on the eyebrows, adnexa, and nose scars.
What is the importance of this line?
So, if the child has undergone any previous interventions, like for the or surgeries over the orbit.
Or maybe the cause of atrophia is trauma. So you are looking for the
Yes.
any scars of a previous trauma. So
Yes.
because one of the important questions to ask yourself whenever you have an atrophia or cysts, what was the cause? You have to ask
Yes.
about the cause, whether in the history or by examination. You have to search for the cause. It's really important because this cause may affect the other eye. Maybe the patient has an issue in this eye, and this issue start to develop on the other eye. Okay,
Yes, ma'am.
so
Yes.
one of the checklists in evaluation of cysts or atrophia to search for the cause, the primary cause of this atrophy. How would you check for ophthalmos? The examiner asked.
So I would like to initially on inspection, I would look as I look for proptosis, like I would do the worm's eye view from down, and I would look if the globe, which globe is more prominent, and
Yes.
then I would like to confirm my findings with the Hertel's exophthalmometer.
What's the normal range? The upper range is 20.
Okay.
The lower number, is, according to my reference, is 12.
Yes, madam, it's 12.
It's 12, okay?
Yeah.
All right. And it's easy to remember. We have 2 in each, 12 to 20.
12 to 20. Okay.
But in addition to saying the range, the normal range, you have to add, we have to keep the gender and the age and the race in consideration. Okay?
Okay.
Because there is a variation in the numbers according to the race. So African, for example, has shallow orbits, so the numbers are bigger in African. Of course, the number may vary in very small young children. Anyhow, so let's see what Dr. Verma said. He said, yeah, can you read?
I answered hurdles not available. Then what will you do?
He said,
Measurement of the rule by the ruler. Yeah.
yeah, keep
The
going.
Navzinger view, worm's eye view, palpate the rim and measure with the scale, rim to cornea.
So I like his way, rim to cornea. So from this lateral orbital rim to the corneal apex. So you have the corneal apex. And you have to make the ruler perpendicular to the cornea plane. Yeah, Lude exophthalmometer is another way to measure. Yeah, you can mention this. I like Lude very much. It's very simple. It's something like more accurate than the ruler and very simple and very easy. So what will you do for the patient, this patient?
So for her, I would, for this patient, I would investigate what was the cause for the left eye itis first. Rule out any kind of malignant cause which might have been there earlier. Then I would discuss with the child's parents, like if they would require any cosmetic rehabilitation for the child. So in case they agree for the cosmetic rehabilitation, then I would plan for further surgical interventions.
Okay, so as you can see, there is a symbol here, bomb sandwich. because remember, I'm a pediatric ophthalmologist. I'm a strabismologist, so I'm waiting for something else, something very simple yet essential, okay, in the management. Actually, the examiner was waiting for this, and he repeated his what before surgery can you offer?
I would
So
I would check
sometimes
for the corneal sensation on the surface of the eye.
since this is in the management in order to see if the patient will tolerate the shell or not. But very simple. It has nothing to do with surgery, but you have to order or check the other eye. Yeah, we mentioned the other eye. Yeah, orbital imaging to rule out any mass or ultrasound CT to see if there is an orbital implant, if the history is suggestive of previous surgery. So suppose the parent didn't want any surgery, no interference. So you will allow the child to go like nothing, and the cause was trauma.
Cosmetic.
You are keen about cosmesis, this is good, but there is something more important than cosmesis. Yeah, tattooing is one of the line to address cosmesis and cosmetic contact lens or shell or whatever. Yeah, so cosmesis is important, but we have like an order of importance. So first, we keen about the life of the patient, and that's why you need to rule out any malignancy here, any malignant cause for these sizes, okay? So I'm telling now, this is trauma. This is not a malignant. There is no fear on the patient's life. So you have to be careful about life. Then vision. So this is no PL. Why we care about vision? But remember, we have a vision on the other eye. How we can protect the other eye?
Safety spectacles.
Yeah, it's really important to mention polycarbonate goggles or glasses or safety. Yeah, you have to protect this child. You have to adjust somehow the activities they are doing in order to protect this eye. This is a single-eyed patient. Any patient single-eyed or has like a fragile eye, even if this eye has some vision, but still fragile or still very has very poor vision, you have to protect the eye by safety glasses or polycarbonate glasses. So again, we are keen, first, life, second, vision, but we don't have vision here, but you have to protect the other eye. Sometimes pain, sometimes we mention pain before vision, because we humans can accept loss of function. We can accept loss of function, but we can't tolerate pain. So pain can lead us to suicide, So sometimes in the order is life, pain, vision. The least one is still important, but the least in order is cosmesis. Okay?
Okay.
So let's see what Dr. Verma said. He said, let's read it out.
Answer that I will try to improve the visual acuity if possible. Said the vision is no PL. I said that I will offer cosmetic correction. How? Eviscerate enucleate with implant and then customized prosthesis. What before surgery can you offer? I said high convex lenses and photochromatic glasses.
Yes, sometimes we order safety glasses, but we make it like photochromatic in order to camouflage the appearance of the other eye.
Other eye, okay.
Convex lens, as you know, enlarges the view, enlarges the eye behind the glasses. So if we have a small globe, we can camouflage and make it bigger by prescribing plus lenses, high convex lens. The vision is already no PL, so there is no harm of prescribing. The only problem is there will be imbalance. So the frame might be tilted because convex lens is heavier. Okay?
Yes.
All right.
Okay.
So we have a big title in ophthalmology called fragile globe. Okay? Like what? Angiodystrix. Someone said angiodystrix. And also ophthalmos, one of the causes. High myopia also. blue any kind of scleritis that result in thinning. This is fragile eye. You should prescribe, safety
The
spectacles.
polycarbonate. Yes.
Okay.
Okay, ma'am.
So here's the order I said before: life, pain. In general medicine station, if the examiner tells you about a scenario of chest pain or like myocardial infarction, you have in the management to prescribe something for pain. Okay, it's really important. Actually, the invention or the creation of our job, the doctors are present to relieve pain. This is the first important function, and then vision, and then cosmesis, and here polycarbonate glasses. All right. Someone added also in fragile eye if they have a corneal issue. It's not only sclera, because cornea and sclera and limbus are the components of the outer coat, the outer protective coat. So if we have a like thinning on the cornea or something in the limbus or sclera. The second experience from Dr. Verma also. His experience is very well written, actually. And he was lucky because he's a plastic surgeon and he got many cases related to his specialty. So can you read aloud? Again, this is in OSCE. This is in OSCE in Oculoplastics station. And I brought this image that could be similar to the real case. Okay? Yeah.
Okay. Old lady with right eye corneal scar and left eye ptosis asked to examine and tell.
Okay, so if you see, I artificially created a scar here. And now I enlarged the photo for you. So can you tell me there is an important sign here? Yeah, ptosis is there because as you can see, whenever we have like larger tarsal show here, so this is relatively a ptosis compared to the other side. But there is an important sign.
Dystopia, inferior dystopia of the left eye.
Yeah, so apparently there is inferior dystopia. Okay. Let's enlarge.
Right side,
But do you
right
know,
side there's a corneal scar.
as Dr. Verma said. Okay, let's see what's the next. Can you read it aloud?
Check health and motility. So a prosthesis in left eye. Commented on the size and fit.
So sometimes patients with customized or custom ocular prostheses have like very nice customized prostheses. So apparently, away from them, you couldn't differentiate or you couldn't elicit artificial shell. But actually, this is a case of prosthesis here. All right?
Okay. Okay, ma'am.
So it's not uncommon to say something like ptosis, proptosis, asymmetry in the fissure, dystopia, as you said, or maybe squint and limitation of the movement. But actually, this is a prosthesis. All right? Here is another question. What can you do for this patient?
Looks like she has post-enucleation contracted socket syndrome with deep superior sulcus and inferiorly displaced prosthesis.
Yeah, it's very common to have like deep upper sulcus with prosthesis. Okay, someone here asked about the evaluation of prosthesis. Now, as I said, in this class, we are not going to say any checklist. So you have to work on your own and make the checklist for prosthesis. I'm going to share you some of the references because Dr. Verma has a class on prosthesis evaluation. Let's see what he said here. Can you read it aloud, please?
Told about asking the history. If any document of implant, would check the surface conjunctiva for any cyst or granuloma, would check the motility of the implant, can get CT scan to see if there is an implant, check for fractures, check the COP for customized ocular processes for weight and fit, and check the fornices.
So as you can see, all these are points in the checklist of prosthesis evaluation. So remember, we have a case of atrophia or scissus. So there is a checklist or points to be assessed whenever you have atrophia. And sometimes you may get a case with prosthesis. So there might be atrophia behind it.
Or an ophthalmia post-evisceration or enucleation or even congenital.
But you have to mention to the examiner, this is a prosthesis. So what are the relevant points, how to assess? Okay, these cases are very easy. because you are not allowed to do a lot with the patients. Generally speaking, it's like a viva. You are going to verbally tell the examiner, I want to
check
1, 2, 3, 4. Okay. So actually, if you see here, Dr. Verma didn't do anything. He just did very simple things, and the remaining of the station is actually like viva, because they are not allow you most probably to remove the prosthesis to check the fournices, for example. Okay. So mostly this point are said verbally. All right. And let's see the management, because mostly the case has a poor fit. So you have to know what is a good fit and what is a poor fit. You have to study this. So can you read it aloud?
Would try to fit a new customized ocular prosthesis. If fornices inadequate, then first make fornices and then the COP. If any fracture, then repair fracture before prosthesis.
Okay, because sometimes the problem is not only on the globe. The problem is bigger than this. Because he is an oculoplastic surgeon, he directed the examiner, or he mentioned to examiner more advanced piece of information. Sometimes there is a fractures on the orbit, because most cases are trauma induced, okay? And also, you have to be careful about the nomenclature, the definition. What's the difference between
an ophthalmic socket and contracted socket?
If we have a shallow fournices, this is called contracted socket, because it cannot accommodate a proper shell or a proper prosthesis. Okay, and that's why he said, I need to check the fournices. If it is shallow or inadequate, I need to do some surgeries to deepen the fournices. I want to tackle the problem of contracted socket first, right?
Okay, ma'am.
Next one.
Oculoplasty. 2. Examine under slit lamp, right eye of old woman, and don't forget that you are in oculoplastic station.
1 second. So I'm just copy paste the experience to make it authentic. Sorry for about spelling mistakes here, because this is woman, not women. It's only one patient. So here it's oculoplastic station, but the candidate was provided by slit lamp. Okay, keep going.
Lid looks normal.
So remember, if you are going to examine the right side, we have 2 eyelids, upper and lower. So if you are examining one side, still we have lids, not one lid. So upper and lower eyelids. You have to examine carefully the upper and the lower. Don't only focus on the lower eyelid, because it's easy to examine it. Also examine the upper eyelid. Keep going.
She has anterior chamber IOL, iridectomy. Again, eye retained back, solid. She has a bicanalicular stent tube. What is the indication? DCR. Why nasolacrimal duct obstruction? Any other indications?
Okay, thank you. So here I returned back. So here the candidate, or she was smart, because she elicited some signs, anterior chamber iridectomy, which is good, but it's not relevant to the oculoplastic station. There must be another important sign related to oculoplasty. Okay, so she repeated again her examination, although she checked the eyelids before, but she returned again to the eyelids. Okay, and luckily she found the tubes, the bicanalicular silicone tubes. So you have to be systematic, or you have to develop a system in examining the eyelid, especially the lid margin. Start medially and then go laterally. Start to see the components of the lid margin, the eyelashes direction, any notch, any swelling of the lid margin, any misalignment of the lid margin, entropion, ectropion, any changes in the meibomian openings. All these points are important. So the discussion was about DCR, because generally speaking, with DCR is coupled with tube. So it's really important to look at the area, to look for a scar. So you found a stent. The next step to look at for any scar. So I have a question for you. If we have an adult, like an elderly patient, and they have like tube, but you didn't find the scar of the DCR, do you have any explanation? There is no scar for DCR, but the patient
Maybe
has
endoscopic DCR?
Yeah, excellent. So it may be endoscopic DCR. This is one possibility. Another possibility, there are other surgeons who still do intubation for acquired, or maybe the indication of intubation due to trauma. Maybe the patient has like canalicular laceration and then underwent intubation. So you have to know what are the indication of silicone tube or bicanalicular intubation. It's not only about DCR, there are other indications like trauma, as I said. Again, you have to notice the difference in the protocol between management of congenital nasolacrimal duct obstruction versus acquired nasolacrimal duct obstruction. So the next, I'm going to read this because this is my experience. It's a bit old, like more than a decade, 2014, Amman. I shared it before. I'm sharing it again because it's really important. The examiner gave me a scenario about the patient, female patient with watery eye. I observed the case and I thought there is proptosis, okay, on the left side. I already have loop exophthalmometer, so I examined, I measured, and I found that it's pseudo. So the examiner repeated his hint, and he told me again, this is a watery eye.
Past history of a watery eye.
And he helped me and say, look closer to the patient. So I noticed slit appearance, or like as if the patient underwent punctoplasty. The lower punctum didn't look like small, it's like a slit shaped. I said there is punctoplasty. Again, the examiner was very helpful. He said, is there any scar or something? Then I realized that there is a scar of the DCR on the left side. Okay, so you see, sometimes the examiners are very helpful, but it's not allowed for examiner to give you a hint or to point out at the part to be examined. But I was lucky, okay? So sometimes the scar of the DCR is very faint, and it's easy to miss it if it is not in your mind. So if there is an information that is not in your mind, it's very difficult to be visible to you. And then he asked me the follow-up question, like what are the types of DCR, external, and then he said, did she had DCR on the other side? I said, there is no scar, but the patient may underwent endoscopic. Then asked me about the steps of the DCR. This is one of the high-yield questions to be asked about the steps of DCR. And that's why it's important to know the anatomy of this area. And he is like paying a lot of attention to the first step, like adrenaline sucked gas in the nose to control the bleeding. And he asked me about the position of the skin and etc. All right?
A last reflection on that experience, that slit-shaped puncta might be due to cheese wiring of a previous tight intubation.
If you are working in an area or institution and you haven't seen DCR before, you have to familiarize yourself with the surgery. You can watch YouTube videos or whatever, or have a kind of observership to watch this surgery, okay? It's not enough to see illustration and photos. You have to see real cases. I like videos created by Ric Caesar. You can watch it. It's like bloodless field. You can appreciate the anatomy and every step very nicely. The next experience, this is an example of a single diagnosis, a pathognomonic lesion. There is no place for giving me a differential diagnosis.
Ma'am, these are comedones, blackheads.
Yeah.
On the upper eyelid.
Excellent.
Multiple blackheads on the upper medial side of the upper eyelid.
Excellent. I'm going to share my model answer for this experience in the published recorded version. There's a lot of follow-up questions. It was a simple case, yet many weren't able to diagnose it. I don't know why they brought this case, but anyhow, it was a case in Cairo last year. And this is another experience. I'm going to share my model answer in the recorded version. Just give me a diagnosis.
This is an external photograph of the right eye of a patient showing upper lid entropion with misdirection of eyelashes.
Mm-hmm. So whenever we have two photos, you have to give me a comment here and a comment here.
Right. So on the eversion of eyelid, the second photograph is showing scarring on the palpebral tarsal conjunctiva.
Yes. And the most common cause
Is trachoma.
trachoma. Especially the case was in Cairo. All right. It's endemic in Cairo. We covered this topic before when we talked about entropion in two classes. My last question for you, I'm going to let you listen as if you are listening to the examiner. I want you to repeat the questions, okay? So this is a kind of like a listening practice away from ophthalmology, all right?
Right. Right.
So pay attention to the questions. If you want to write it down, it's okay. 1, 2, 3.
In a voice note, describe the findings. What are the expected symptoms? What's the possible etiology, complications, diagnosis, and how to assess such case and the management?
So she mentioned 7 points. Can you recall them all?
So, she asked about the symptoms
Mm-hmm.
and management,
Mm-hmm.
how to manage this patient,
Mm-hmm.
and examination.
Mm-hmm.
No, I don't remember anything else.
Yeah. The message from this slide is to pay attention to the questions asked. In order to answer correctly, you have to listen carefully at first. So let's repeat it again.
In a voice note, describe the findings. What are the expected symptoms? What's the possible etiology, complications, diagnosis, and how to assess such case and the management?
All right.
Yes, ma'am.
And you will find my model answer in the recorded version, inshallah. Okay. We finished the cases. The fun part now is quizzes. Before we start the questions, I have a question. Okay?
Okay.
This is a test to pay attention to my questions, to listen carefully. All right? I want to emphasize again that if you are following my classes, especially in the quiz part, I usually incorporate questions that not merely test your ophthalmology related knowledge, but also it's a kind of practice for higher thinking skills and you're guessing how you can give me educated guess how to think quickly. So how you can give me an answer even if you don't know the answer. So yeah. So my question to you at first, if we have a disorder, and the disorder is graded into stages, right? Starting from stage 0 to stage 5.
Okay.
How many stages do we have?
6.
Okay, excellent. Do you know a disorder that we have like stages from 0 to 5 in ophthalmology?
In 0 to 5, dry eye. No, it's not. It is a retinopathy of prematurity.
Yes, excellent. So I like your way when you are thinking loudly. So sometimes better to think aloud instead of giving the examiner a long pause. Don't ever give the examiner a long pause. If you are thinking about something, say it loudly. Allow the examiner to know that you are thinking and you are not going blank. So you are thinking, you are processing the information, trying to figure out an answer. Thank you. Let's see the first question. Question number 1. How can you relate to this photo? Ophthalmologically speaking. This is a kind of analogy. This child, this cute child, is giving us a gesture that you can relate it to a disorder or a sign in ophthalmology.
Madam, it's a lovely baby, but
So someone is helping you.
yeah,
Do you see this mouse? His mouse or her mouse?
yes, punctum,
Yeah, this is called pointing by P. Pointing.
punctum, yes.
Yeah, excellent. Pointing, punctum. And let's enlarge this. Actually, this is taken from a photo, but here the examiner is manually applying traction on the lower lid. This is not an ectropion. So
Okay.
it's good to notice that if the examiner shows you a picture like this, you may ask the examiner, is someone is applying traction on the lower lid or not? Because if nobody is applying traction, this is an ectropion. Okay, this is an ectropion. But here I am pointing out that there is manual downward traction. The examiner here or the photographer is applying traction on the lower lid in order to show us the pointing of the punctum. All right?
Yes, madam, I'm hearing you. Thank
So
you very much.
what is the implication of pointing of punctum? What does it signify if we have pointing of the punctum?
Madam, it can show the canaliculitis.
Yes.
Or
So it's written in
yes,
Kanisky under the disorder of canaliculitis.
yes.
By the way, what's the meaning of canaliculitis?
It's the inflammation of the inferior or superior or common caniculum.
So you may add another word, chronic. It's a chronic. So by definition, it's a chronic
It's a
inflammation.
chronic inflammation.
So we have a lot of C's here. Chronic canaliculitis. Excellent. Thank you. Next,
Thank you.
volunteer. So this is another analogy. Okay. How can you relate to this photo?
Cheese wiring.
Yeah. So if you are interested in kitchen utensils, this is called what? Egg slicer, and this is cheese slicer, and we make like cheese wiring. So what is the cheese wiring here? This is an example of cheese wiring, upper punctum. So if you see this in a patient, this is a telltale sign of what?
3 snip canaliculoplasty, ma'am.
It is called 3-snip punctoplasty.
This is one possibility, another possibility. But my question was about cheese wiring. So cheese wiring was mentioned or is mentioned with something else as a complication of something else. Cheese wiring is a complication of something.
Cheese wiring of the tube after DCR.
Yes. If the patient has a bicanalicular or intubation and the tubes are too tight, okay?
Okay.
It may, probably will result in this cheese wiring. So probably this patient underwent intubation, and sometimes they presented the case without the tube because the tube is not forever. Usually they remove it after 6 months, but still the cheese wiring is there. So
Okay.
cheese wiring as a term mentioned as a complication of tight tube or tubes, okay? But if we are talking in general, like what can cause this appearance slit-shaped of the punctum, you may also add the 3-snip punctoplasty you mentioned. All right?
Okay.
Excellent.
Okay.
Thank you. Another one?
Thank you.
Oh, yeah. Someone else says trauma. It could be trauma. Yeah, maybe. So before we go to the next questions, this is quick photos I compiled to show different signs in the punctum and in the inner cancers area. So quickly, what is the sign here? There is something here.
Cheese wiring, madam.
There is something rounded like a tube in this area.
Monocanalicular stem.
No, because again, let's make a pointer here.
Less than just tube.
The punctum is the puncta are free, are here, but there is something here in the inner.
Jones tube.
Yeah, excellent. The next one. This is
This
tube.
is
Bicanalicular.
Yeah,
Plus,
bicanalicular.
there is some kind of cheese wiring here. The puncta here are huge. Okay. Next, this one. What is the sign here?
Central plug.
plug here. Excellent. And let's see this one. This is just intubation, nothing else. Here, there is no manual traction. There is no traction of the lower lid. What is the sign?
Medial
Lower lid
ectropion.
ectropion.
Yeah, lower lid ectropion, like a small degree, but you can appreciate that there is a gap between the lid margin and the globe.
Sclera show.
Sorry?
Is it sclera show?
Cicatricial?
Sign?
No. In order to say cicatricial, there must be scarring on the skin side. Okay? So this is probably involutional. And this is again the pointing I showed before. Okay? So imagine now a case like this, and they may ask you to examine such case on slit lamp because it's much easier to see these signs on slit lamp because slit lamp provide light and magnification.
Is there a shallowing for in picture E? Is there a shallowing in the inner yeah
Shallowing?
yeah.
What do you mean by shallowing?
Pica similionaris here medially.
Yeah. You mean here? Yeah. The picture is not complete, but maybe I don't know. But here's a sign. If you are confused, you have to mention the most significant, the most obvious one, and then you may add anything you are suspected or you also have a suspicion about it. So the most important here, especially I said, there is no traction on the lower lid. I shared this photo before in the ectropion class. This is like a grade 2 ectropion. And sometimes we have grade 1 ectropion. The ectropion is only affected the punctum. Yeah, only the punctum. Because in involutional ectropion, it usually starts medially. All right. Another photo is important here, just a kind of quick revision. When we have a conjunctival redundancy here, this flap or this part of the conjunctiva, it might obstruct the punctum and causes epophora. What we call this condition?
Conjunctivocalysis.
Excellent, conjunctivocalysis. And here, unlucky
Lash in
patient.
the punctum.
Unlucky patient has a lash in the punctum. And here, if we have a large pruncle, it might displace the punctum away. So it's not only enough to examine the punctum for patency, but you have to see if it is co-opted to the lacus lacrimalis or not. And we showed before Centurion syndrome, when we have a large prominent nose, the punctum might be away from the globe. So don't ever forget inspecting the punctum in the workup of epophora. And sometimes the punctum is obstructed or stenotic because of the bigger problem, like cicatrization of the conjunctiva, as in this case, as a result of drug-induced cicatrizing conjunctivitis. And that's why I really like the one who commented on the plica. So you have to examine also the plica similaris, the inner area of the cancus for any scarring or any shallowing, as she said. The next question.
Like tube.
Sorry?
It's like tube, like silicone tube or something.
No, silicone tube has two parts. Like there is something strange about this. There is something cut here, something is cut here.
Yeah.
This is actually an illustration. Suppose this is the punctum, okay? Suppose this is a punctum, and you know that we have punctum and they have a vertical part, canaliculus part, and we have a horizontal canaliculus. So what happened to the punctum and this vertical canaliculus? There is something missing here. We have a surgery in which we remove part of the canaliculus, the vertical part of the canaliculus, and part of the horizontal, actually. Do you need any help? Let's check the chat here. Yeah, someone wrote the answer. So 3-snip punctoplasty. 3-snip punctoplasty. This illustration is not clear, but you have to revise this surgery because we use it in case of punctum stenosis. All right. But now you can imagine and appreciate the illustration after seeing the operation. So this is actually the illustration of the operation. So don't ever forget the evaluation of the punctum, inspection. Is it present or absent? The size, shape, patency, and this is an example of clinical problems, clinical signs. Next question, number 4. So we have an English expression or idiom that can describe this photo. Now it sounds like an English. Yeah, one stone. Yeah, kills 2 birds with one stone. Okay. So what is the question? By applying fluorescein on the on both sides, we can do 2 tests at the same time, right?
Yeah. One is fluorescent dye test and the other is Jones dye test.
Okay. What is the abnormal side here? Is it the right side or the left side?
The right side.
The right side. And give me the results. Give me documentation. How you can document?
So so the fluorescent dye disappearance test is positive, and Jones dye test, it depends, like it's not shown whether
But
staining.
imagine it is not present. There is no fluorescein here.
It is not present. Okay,
So it is,
then Jones test is negative.
yes. And on the other side, this is the healthy side.
The other, okay.
We have
The other side,
negative fluorescein appearance test, positive Jones one. Okay, excellent.
Yes.
It's very confusing. All right. So this is another reference. As you can see here is the concentration of fluorescein, 2%. I'm not sure if the fluorescein concentration in the filtered paper is 2%. I'm not sure. It's not written. Next question. This is almost a single diagnosis.
Dacryocystorhinostomy.
Yeah. What is the other name?
Amniotocoel.
Okay. What is the age of the patient?
Newborn.
How do you know? There is
Usually.
a newborn towel here. Okay. So usually newborn, the eyebrows, you know, there is a specific name for the hair. I think they have a name. And the nose usually look like, yeah, it's a newborn. So why it looks blue? Because sometimes if you see a bluish mass, you may think of vascular, right? You may think of vascular component, but actually this is not a vascular component. This is an optical phenomena due to stretching of the tissue, and despite the amniotocoel is just an amnion or fluid, but it gives you a bluish discoloration. This is a descriptive, one of the descriptive features of amniotocoel, bluish discoloration. So very good that you mentioned the sign and the diagnosis. Now you have to expect the follow-up questions. You have to know how to manage a case with amniotocoel. It's a really important topic, and you have to think bigger, and you have to know, suppose the examiner asks you, what are the differential? Although this is an amniotocoel, but he wants to see if you know other lesions or other swelling in this area. So you have to know what are the cause of medial cancer swelling in this area. And we have a dangerous cause. Do you know the dangerous cause?
Encephalocele.
Yes. What is the basic difference between encephalocele and amniotocoel?
We cannot, means retropulsion is not possible in this one, but encephalocele we can retropulse the pulsatile swelling.
Okay, what else? The level. Also, the level is important.
Will be above the medial canthal tendon.
Yeah, this is really important. Actually, it's taking the shape of the lacrimal sac, and it's mainly below the medial palpebral ligament. Excellent. This is a summary of some lesions in the medial cancer area. So here, acute dacryocystitis, it's contraindicated to do regurgitation test. And what's the difference? You have to know the difference between acute and chronic. Of course, here is inflammation, tenderness, but here everything is quiet and white. And sometimes we have fistula or abscess and spread of infection to the surrounding tissue, preseptal cellulitis. All right. So again, I am sharing the diagnosis, but you have to know how do you manage. Okay. Sometimes we have fistula. This is another indication for fluorescein. So you see the fluorescein coming out from the fistula, and you have to think again bigger. We have two types of lacrimal fistula, congenital and acquired. All right. And sometimes we have a scar here. It could be healed lacrimal fistula, or it could be a scar that needs like scar of the previous external DCR. So we also look for scars. See some of the examples of lesions in the medial canthal area, swellings and scars and fistula. Next. This is a pathognomonic lesion, single diagnosis. So suppose you don't know the lesion. You forgot the name. What is the other way? Describing the lesion. Don't stay like, don't go
Yeah,
blank.
this is a it's a transeliminatory swelling. This is a swelling in the medial canthus involving the lower lid, and it is transeliminating. So
the contents, when the lesion transeliminates, what does it mean?
Yes. It's clear contents.
Okay, fluid, like clear fluid, like watery. Actually, because this is a huge mess, but actually, if I'm helping you right now, I'm telling you, this actually a lesion starts from the lid margin. It's something.
Yeah, then it is cyst of Moll. Moll is
Yeah, excellent, well done. So this is a pathognomonic lesion, cyst of Moll, or the other name is epicrine hydrocystoma. You have to know how to do transillumination, by the way. You have to dim the light, turn off the lights, and bring a pin torch or light source on one side and see. But you have to look closer to see the beginning of this cyst because it's huge. You will see that it's coming from the lid margin. Because if you study the cyst of Moll, you will see that it comes from the lid margin, from the cyst of the, this is another photo for another reference to show you how do you do the transillumination.
Okay.
Again, there is a checklist for eyelid swellings. So suppose you have a case in OSCE and there is a swelling of the eyelid, you have to keep in your mind what are the points to be assessed whenever we have a mass or a swelling or a lesion. And don't forget to comment on the lymph node because it might be a malignant to metastasizing to the lymph nodes. And Dr. Verma has a class on evaluation of eyelid masses. And you will find transillumination is one of the points. Okay? And start by telling the examiner you need to ask about some points in the history. Age is important, complexion is important. In the recorded version, you may pause on this slide and see the points, but it's not organized because this is not a class about eyelid lesions. Here I compiled some important pathognomonic eyelid lesions. So all of the photos, each one is a single diagnosis. So quickly, what's this one?
Keratosis.
Basal cell papilloma.
Yeah, basal cell papilloma or seborrheic keratosis.
So seborrheic keratosis. Excellent. The second one?
Papilloma.
Yeah. The full name is squamous cell papilloma. Okay. This one? We have lesion at the upper. No. Yeah, it's a mechanical ptosis, but we have lesion here in the upper.
Amylonotic kissing nevus.
Excellent.
Nevus.
It's a bit amylonotic, but this is a pathognomonic of kissing nevus. Okay. This one?
Molluscum.
Marginal lid molluscum contagious.
Make sure to say the full term. Okay, and this plaque-headed
Comedones.
This is a patient underwent previous excision of sclesion.
Myogenic granuloma.
Myogenic granuloma. And this is one?
Herpes simplex.
Mostly type 1. Mostly type 1. And here? Melia.
This is Melia.
By the way, Melia is somehow similar to herpes, so but this is Melia. And here, cyst on the lid margin, clear, transilluminate. Cyst on the lid margin, but not clear.
Cyst of lice.
Cyst of
Zeiss.
Zeiss. A young child, congenital onset, has a
Capillary hemangioma.
capillary hemangioma. Excellent, excellent. So again, we are just mentioning the diagnosis, but you have to say, how do you manage each? You have to study this. I'm just sharing the key answer here. There's a different ways to classify eyelid. So you have to differentiate between eyelid swelling, because it may be diffuse swelling, like in allergy, but sometimes we have mass lesion. It might be classified into ulcerative, non-ulcerative, pigmented, non-pigmented, transilluminate, not transilluminate, okay? And is it cystic or non-cystic? Sometimes we need to do biopsy and to check the histopathology, how to excise, how to repair, the workup. You have to decide, is it benign, borderline, there's a potential for malignancy, is it malignant, if it is locally invasive, or if it is can metastasize or not, okay? And you have to know the signs suggestive of malignancy, like loss of eyelashes, non-healing, and so on. Dr. Verma has a class on many things. You may interested to check his channel. He has a class on ophthalmic socket evaluation, eyelid swelling. Okay. The next question is very tough. It's a chemical substance. It has a yellowish appearance and
sulfur granules.
Sulfur granules. Excellent. In cases of what?
Actinomyces israeli.
So it's not enough to say canaliculitis or chronic canalitis. You have to be specific about the causative organism. Okay?
Okay.
And you have to know the management. How do you manage this entity? By the way, it has nothing to do with sulfur. It doesn't contain sulfur. These substances don't contain sulfur granules. This is a kind of analogy. It looks like sulfur granules, chemically speaking, but this is not sulfur. It's just a collection of inflammatory cells plus the organism. All right? You have to know a little bit about the microbiology here. All right. So if we enlarge it here, actinomyces infection. And as I said before, any canaliculitis, it is chronic by nature. So we chronically inflamed, and it is caused by, and we have something pathognomonic, which is called sulfur granules. And you need to do incision and curettage.
Okay.
And according to this reference, but it's an old reference, it's mentioned to use penicillin. But check Kanetsky, okay?
But actually, there is something called acute canaliculitis, and the classic example is herpes simplex.
The next question, you are staying away from the patient in OSCE. So can you mention a sign? And here's a red flag. So this is a trap. I'm going to trick you in this case. A child, what is the sign? Or what are the signs? You are staying away from the patient.
Okay.
Is it wise to stay closer to the patient? Is it wise? In oculoplastic station, remember, this class is about oculoplastic station.
Yeah.
So you need to stay closer
Sure.
a little bit. So are you going to stay closer to the patient?
I have to go away from the patient.
No. As you can see, the photo is small and far away from you. Is it wise to stay closer and to have a bigger picture of the patient or not? Say yes, I need to stay closer.
Yes.
Yes, okay.
Yes.
So if you stay closer, you have enlarged image.
Okay, I can feel that in the left eye is the palpebral fissure is narrower than the right eye.
So as we have asymmetry in the palpebral fissure.
And also,
and we have dryness here. So we have dryness here and we have lacrimation here, right?
Heterochromia, I think the left eye.
And the iris here is dark and here is brown. Okay. And I noticed that there is no vasculature on the sclera here. The sclera looks what?
It's a prosthetic eye.
Yeah, exactly. So that's why it's very easy to miss prosthetic eye if you are away from the patient. you may notice the secondary changes, like ptosis, like deep upper sulcus, like squint, like limited motility, dryness. What else? Well, like heterochromia, okay? Because sometimes the customized procedure is not exactly 100% as the other eye. But if you stay closer, you will notice that this is actually a prosthesis, okay? So never ever forget prosthesis or miss prosthesis because this is a fatal
mistake.
And this is another patient. By the way, sometimes one of the features of poor fit, so this is important. Poor fit, you have to see laxity of the lower lid, exaggeration of the process of ectropion. So sometimes we have something called
an ophthalmic ectropion and an ophthalmic ptosis.
Sorry about the spelling mistake here. It's very common to see asymmetrical fissure in prosthesis, okay? Especially with poor fit. And if you are going to test the motility, definitely there's much limitation in the motility. And again, there is heterochromia, but all these are signs, but collectively doesn't count anything. If you missed prosthesis, you have to say this is a prosthesis. This is like the first answer you should say, because the follow-up questions is about how to assess the prosthesis. All right? Got it? So this is a funny scenario, but it's sad. So imagine a candidate who mentioned everything: heterochromia, squint, limitation of motility, dilated fixed pupil, no PL, hard stony IOP. But at the end, this is a prosthesis, not a real eye. There's a nice video on YouTube by Ritesh Verma about assessment of prosthesis. I'm going to go fast. Another video by another doctor. I really like this video. It's yeah, well done. With another video about ophthalmic eye by CyberSight. I will share the links in the video description. By the very famous one, Dr. Hanover Sir. Okay, he has two videos actually on evaluation. One of them is very detailed, that belongs to iFocus online channel. So the last thing regarding this point, actually, this is one of my, was taken from my experience. And it was in Viva. I was given a picture of empty socket, right? I started my answer by saying I want to order CT. This is like a bad start, because you never start your assessment by mentioning an examination, an investigation. So you have to start by history, examination, inspection, and so on. Back then, I haven't prepared to answer a question about empty socket. So the examiner wasn't happy at all. Although this is correct to say it, but at the end, not at the beginning. So the examiner was about to, this is my words, to throw his shoes at me, but luckily I passed the questions, okay? So sometimes the order, how to give an organized answer is important. Start by history, examination, and then investigation, and try to be less invasive at first and then invasive at the end. Okay? Question number 9 is very tough. This is a kind of ruler, transparent ruler, but it's very like miniature, like very small.
Yes, madam.
Have you ever seen this before?
No, unfortunately.
Neither do I. Okay. So this
Yes, in my clinical practice, I do not use this.
Now, can you guess its uses?
Yeah, of course, madam. It can be used in measurement of the ptosis.
No.
In general,
No,
in
look at
eyelids.
this. Look at the screen now. Look at the screen now.
Yes, I'm seeing the screen.
So when we measure the ptosis, we don't apply something inside the eyelid. So as you can see,
yes, you are right. You're right.
To measure the furnaces.
Excellent. Who said this? So actually, this is a fancy tool. Okay, I think for research to measure the depths of the upper fornix. So in the upper photo here, it's the ruler is inserted yeah in the lower fornix. Okay, so this in the lower fornix to see how depth it is, and here to measure the depth of the upper fornix. And the patient is asked to look opposite. Like if you are going to measure the lower fornix, ask the patient to look up in order to put the fornix under stretch, okay? And when you measure the depth of the upper fornix, you ask the patient to look down. This is a bit fancy, but it might help you to remember how it is important to check the fornix in your evaluation, especially when you are going to evaluate a case of prosthesis. Is it proper fit or poor fit?
Can anyone name this?
This thing, this ruler?
Yes, this ruler, the name of this ruler?
It doesn't have a name. It's just a ruler. Yeah.
Okay. Okay.
Yes. And you have to know what are the causes that might cause shallow fornix, like symblepharon, chemical burns, and so on. Last question. It's actually not a question because we don't know the diagnosis of such a case until now. It's a real case, one of our institution cases. But sometimes it's like a puzzle. Which side is the abnormal side? Okay. So what do you think? Is it fullness here? Or is it deep sulcus here? Is it proptosis here? Or enophthalmos here? Yeah.
Madam, both of them may be in association, yes.
So the aim of this photo quiz is try to, sometimes you may think that the one side is the abnormal side, but actually the other side is the abnormal side. So try to be open and look in the eyes of the examiner. Try to appreciate whether what you are saying is correct or not. Because all possibilities are here, are present, are relevant. This might be a proptosis, there might be enophthalmos, this might be a fullness here. Maybe this is deep sulcus, okay? By the way, this patient has a medical history of thyroid. So you may think this is a proptosis. But again, she has a past history of breast cancer. So it might be some sort of enophthalmos here. And also the patient in her late 50s. So this kind of fullness might be normally like blepharochalesis or redundancy. Many people have like buffy upper eyelids. And actually the patient was stating that this side looks abnormal for her. So I want to share with you that you have to, in the history, to ask the patient to bring all the photos. It's very simple, but sometimes you have to say it to the examiner. All the photos are really important in order to decide. Sometimes it might help to decide which side is abnormal. Of course, you are going to examine, you are going to investigate, imaging, and so on. So by Hertel measurements, actually the Hertel measurements are borderline because the right side is like upper normal.
But we have 3 millimeters of asymmetry between both eyes, so this case should be taken seriously.
You can't decide is it proptosis or enophthalmos. The condition is still subtle. By the way, there is something missing here in Hertel measurements. Do you know what it is? When you are going to document the finding using the Hertel, you measure the two. Yeah, someone said the base diameter.
Base diameter, yes.
Yeah, base diameter. Because if you are going to repeat the measurements with a different base diameter, definitely it will give you another numbers. So you have to make the base diameter constant every time, on every visit. So it is like a puzzle, as I said before. It's really important to take history, examination, and ask about all the photos. Of course, you need investigation, and you have to be familiar somehow, if it's possible. How do you measure Boer Hertel? You measure proptosis by Hertel.
Madam, I have a question. May I?
Yes.
In the same patient, does the base diameter differ or change?
No. It doesn't change.
It doesn't change. Yes.
Because it's a distance between the lateral orbital rim. This is a bone structure. It's fixed unless the patient underwent trauma or surgery, like orbitotomy or something. So what are the errors in Hertel? The most common error is something related to the operator. He doesn't know how to use it. But maybe the patient is not fixating straight ahead. By the way, if the patient has a squint, you have to cover the other eye. So if you are going to measure the right eye, and the right eye has exotropia, so you have to cover the left eye in order to allow the right eye to fixate like straight ahead in order to give an accurate measurement. The standard way to use the Hertel is like in this video. This is from Iowa. You can check it out after the session. So you are sitting, okay. You are using your right eye while measuring the patient's left eye, and using the left eye here, the doctor's left eye, while measuring the patient's right eye. This is the ideal way. But actually, in my proptosis evaluation, I was standing because we expect in the exam to be standing. I think they don't provide you with a chair. Usually you are standing in front of the patient, and that's why in my video I was standing. Second, I was a little bit closer to the patient because I am myopic, so I removed my glasses, and I am also presbyopic, so I wanted to sit closer to the patient in order to find the sweet spot. I can appreciate the measurements in order to see the measurements clearly. Another thing that I used my left eye because I'm left eye dominant while measuring each eye. But I think it doesn't really matter because when you are familiar with Hertel, the most important thing is to take your measurements with zero parallax. Where is the zero parallax here? Here I am. You have to align the red line here in front of the middle of the white line posteriorly, and then take the measurements. But ideally speaking, according to the description, you use your right eye while measuring the patient's left eye, and using the left eye while measuring the patient's right eye. All right. So we finished the quizzes finally, and the good part that we don't have closing slides. Okay. Just a reminder that I compiled the previous classes in a playlist called Mock Clinical Practice. We finished now 14 classes, and I have another series called Mock Viva Practice. We have only 4 classes. All right. And finally, we came to the end, and we completed the Oculoplastics classes. The next topic will target the most dreadful station for some of you, neuro and ocular motility disorders. Because they are 2 big entities, I will start by neuro. It's not uncommon to have like a result like this. The candidate did great in all stations except in neuro station. He failed, he got 2 fail marks. This is a very challenging station. I wrote down some important points that I'm going to discuss. Confrontation, visual field testing, pupils evaluation, cranial nerves assessment, eyelid retraction, myasthenia gravis and other myopathies, cerebellum manifestation, multiple sclerosis. So these are points related to the neuro classes. And then we have strabismus and nystagmus classes in the far, far, far future. Okay, so the next class I'm going to talk about visual field confrontation, I mean. You will find the full video at the end of the recorded version, along with a bonus regarding the etiquette while examining the patient. I want to thank those who helped me in shooting the video. Yeah, thank you, and it's over to you. So what does it mean it's over to you? The power to succeed generally is in your hands. We are only guiding you, but your hard work and dedication will determine your future, okay? How far you can go, all right? So believe in yourself and do your best, and wishing you all the best. And thank you for staying with me until the end of the class. Be a good observant. This is a nice slide, right? With a lovely flower. But if we enlarge this one, you will find some written words here. Every finish line is the beginning of a new one. Thank you all, and have a nice evening. Goodbye. Bye-bye.